Bismillah ar-Rahman ar-Rahim. It's a pleasure and honor to be today in the ninth conference of the Department of Clinical Oncology at Ain Shams University. This will be the second session, will be dedicated for colorectal cancer. The first speaker will be Professor Walid Arafat, and he will give us a talk about the application of liquid biopsy in colorectal cancer.
صباح الخير عليكم. At the beginning, I want to thank very much Chairperson and especially Dr. Iman and Dr. Muhammad Yassin for inviting me. وبشكر زميلي فاروق لأن ده مالي الكونسيبت بتاع الليكويد بايوبسي ده من بنات أفكاره. In very short presentation, I want to convince you of the importance of circulating tumor as well as circulating DNA as a surrogate for response and prediction response. So, اعمل ايه يعني؟ ماشي اوكي. بوظت لي البتاع. So this is I like this figure. This is a representative of the early stage of metastasis. Why we are looking for CTC? Because the early step of metastasis is the cancer cell detached from the primary tumor and then invade the blood circulation and then survive for a while in the circulation, extravasate into distant organs, and proliferate at secondary sites. And this figure have been depicted from a chapter done by my student, Yomna Khamis, and it's linked here in Elsevier. Please read this chapter. It's very comprehensive and very nice. So, why circulating tumor cell is a good surrogate biomarker? There is increasing evidence, as I will show you, that CTC, or circulating tumor cells, that enter the circulation could be a good surrogate marker for prognosis as well as detection of and monitoring of the disease. In this regard, the potential use of CTC has increased and has been developed especially for selection of new adjuvant and adjuvant therapy. I will show you detection of recurrent disease, examination of pharmacodynamic biomarker. This is very important, and identification of novel therapeutic target. Now we can enable personalized therapeutic approach by this new methodology. So in these 3 slides, I will talk about the advantage of liquid biopsy. I think in few years, it will be unfair to compare liquid biopsy by traditional tissue biopsy. Why? At the beginning, it's less invasive. The tissue biopsy is just a snapshot of the disease, especially I'm talking about metastatic disease. While liquid biopsy involves either the circulating tumor cells or circulating DNA, analyze and provide a real-time information about disease burden, and most importantly, evolution of the tumor and the tumor heterogeneity. Very important, as I will show you later. The molecular and genetic profile of CTC represent a possible alternative to study tumor subpopulation during disease progression and to monitor change in response to therapy. More advantage of CTC, it's a powerful tool in early screening. Yes. And the monitoring disease progression during treatment and indication of cancer relapse. CTC have a great potential to provide clinical and therapeutic information when combined with downstream analysis. And you can easily detect KRAS, EGFR, HER2 by this methodology. Finally, the difference between individual CTC and primary tumor may enable new insight through comparison of CTC genome with those of the primary and metastatic tumor. This is very important in research area and drug development. Additionally, RNA profiling or sequencing on single or pooled CTC can provide extensive information to identify signaling pathway, splice variant relative to metastatic potential and therapy resistance. Finally, ex vivo can be done using the circulating tumor cells to predict response to chemotherapy in a multiplexed proteomic analysis. So how we can detect circulating tumor cell, or how can isolate CTC? The only available and FDA approved so far is what is called cell search. And in cell search, they depend on the new methodology of isolating CTC, and they count the CTC. They done it for breast, prostate, and for colorectal. For the count considers high risk for metastasis if the number are 5 in breast and prostate, and it considers high risk in if the number are 3 or more in colorectal cancer, and we collect 7.5 milli of the blood. So what is the challenge in colorectal cancer? In colorectal cancer, we have two challenges. In stage 3, we are curing patients, 50% of the patient cured by surgery alone. This means 50% of the patient overtreated. On the other hand, in stage 2, we don't give adjuvant chemotherapy in 20% of the patient, depending on clinical pathological criteria, and this patient failed. So we have two problems here. From here came the concept of minimal residual disease, as we see it in blood disease or hematological disease. And if you have a localized colon cancer and you are treating for curative intent and you are taking samples for ctDNA, and if it is positive, this patient could be not cured. If it is not, if it is negative, this patient could consider it cured. Why? Because circulating tumor DNA is a very positive predicted value for minimal residual disease. Almost 100% positive, 0% false, because you will not only you will see mutation only either in cancer cells or in pre-cancer cells, and you will never see mutation in normal cells. This is a nice study done by Tai and published in Translational Medicine 2016. And this is a clever study where he collects blood sample and look for circulating DNA after surgery and after adjuvant chemotherapy in stage 2 colon cancer. And guess what? As you can see here clearly, patients who tested negative for circulating DNA have stayed a very good local control, while patients who have positive post-operative circulating DNA showing a very bad omen, and BFS was only 2 years. Same happened after chemotherapy, as you can see on the right panel. This is a very nice trials, also published in JAMA 2019. And in this publication, they looked for almost 100 patients, and these patients, they took samples circulating DNA almost 4 to 6 weeks after surgery and also after ending of chemotherapy. And as you can see very nicely, patient who negative after surgery enjoyed a BFS, high BFS level, almost 90%, while patient who tested positive after surgery, having almost all of the patients relapsed. And as you can see, even patient was getting adjuvant chemotherapy and tested positive after chemotherapy still have a bad prognosis, as you can see here. So the fact is, circulating DNA detects minimal residual disease, and it is a strong predictor of recurrence after curative surgery and after adjuvant chemotherapy. And the challenge now, how can we use circulating DNA to improve patients' outcome? Could we give chemotherapy to those patients who in stage 2 who are clinically low risk but having circulating DNA? Could we give them chemotherapy? Could we not give chemotherapy to stage 3 who are clinically high risk but circulating DNA are negative? This will be answered by several trials, including Dynamic 3. It's a huge trial. As you can see here, it's a randomized trial. 1,000 patients with colon cancer. They have collected circulating DNA after 6 weeks of the surgery. They ask the clinician to nominate drug for them, and then they randomize them into 2 parts. The 500 patients will getting the standard of care as the clinician choice. The other 500% will be randomized according to the circulating tumor DNA. Either you will follow, if you are negative, you're trying to down escalate the chemotherapy. This means if you will not give chemotherapy because of the clinical pathological staging, you will not give chemotherapy. If you're gonna give 3 months of capecitabine, if you're gonna give 5 months of 5FU, you give only 3 months. If you will give 3 months of Folfox or Cabox, you give 5FU or capecitabine. If you're gonna give 6 months accordingly clinical pathological Folfox or Cabox, you give only 3 months. And the same, you escalate for circulating DNA positive. If you will not give chemotherapy and you find positive circulating DNA, you will give 5FU. If you will having, if you have clinical pathological risk factor to give 6 months of capecitabine, you give Folfox. You escalate to Folfox. And the same for 3 months of Folfox, you increase to doublet Folfoxiri. And if you want to give 6 months of Folfox, you give at least 3 months of Folfoxiri. So you escalate if you have a circulating DNA positive. And oops, can I have more time, please? Another trials, it's called the Pegasus trials, and this is a Spanish group led by Taberno and in Italy, Bianchi. And in this trial, almost the same, but they look for liquid biopsy and they guide treatment of stage 3 and high risk stage 2 according to circulating DNA. You give if you tested positive, you give Cabox. If you tested negative, you give capecitabine, and then you start following the patient in a dynamic way. And if you found the patient is positive after treatment, you consider them as a molecular metastatic. This is very nice and clever trials. So even you are giving 3 months and you see that circulating DNA are there, you consider the patient is molecular metastatic, and you change the chemotherapy into FOLFIRI. And if you find it negative, you keep the chemotherapy as it is. Of course, we are waiting for this trial. So the concept now, you can deploy adjuvant therapy to stage 2, and also you can, and to answer this, we have, as you can see, like 7 or 8 trials in different parts of the world, USA, Europe, and France, and Germany. All of them trying to escalate treatment for stage 2 according to circulating DNA. And also you can deploy therapy from stage 2 to stage 3 by decreasing the or de-escalating the chemotherapy, as I mentioned. And this is a very clever trial. It's called Circulate by Spain. And they also follow up patient with stage 2 by circulating DNA. They give chemotherapy or not giving chemotherapy, and they escalate to FOLFIRI if it is positive. Still positive. So can we deploy novel therapy? This is a challenge. As you can see in this nice graph, this is a graph of patients who have been circulating DNA. And as you can see, 100% of patients with circulating DNA will have a radiological relapse. So we have 9 months ahead to detect metastasis by using circulating DNA. So I think by this scenario, we can apply a novel treatment, and there is many trials trying to prove of the concept of using novel intervention in positive circulating DNA. And one of the proposed is a trail-based treatment. And we have used that in a preclinical data, and we get a good response. And now it's moved into phase 1 trial. So circulating DNA in early colorectal is challenging. We have incremental improvement in circulating DNA technology, increase in comprehensive panel, increase in sensitivity, however limited by biology, and the false positive are there because of the clonal hematopoiesis. Finally, I will show you, this is a real life patient who coming for consultation, and she's a young lady who have a high risk of colon cancer, and she did CTC concentration, and as you can see here, there was 5 cells per mil. This means positive, and the circulating DNA showing increase of the high risk genes. As you can see, increase in the angiogenesis, increase in the signal transduction pathway, growth receptor, and cell cycle also were rapid. So the conclusion to Madame Jihan here is to give these possible drugs that could affect her in the adjuvant setting. However, because lack of evidence in NCCN, we consider this is a clinical trial, and we cannot advise for such cases till now in adjuvant setting. And finally, I saw this nice paper published yesterday about the liquid biopsy to detect early molecular response and predict benefit as a first-line chemotherapy plus cetuximab in metastatic colorectal cancer. This is the platform B study. It's a Spanish study. And in this study, they follow up circulating DNA, especially after cycle 3. And they found that patients who did well and turned into negative in cycle 3 have a good prognosis, and they consider this is a surrogate marker for continuation of the treatment. And the patient who showing resistant and mutation resistant after C3, they consider it a bad prognostic factor, and they change the treatment, and they send patient into clinical trial. Take home message: Circulating DNA detects minimal residual disease. It's a powerful marker. I hope I convince you with that. It's important to use it as the right technology to detect minimal residual disease. Also, there is no inter-technology comparison till now, and implementation of a strategy to decrease false negative is important. And circulating DNA will it change the way, I believe, circulating DNA will change the way we treat localized CRC, and also will provide a very good surrogate marker for clinical trial to show new drug development. Thank you.
Thank you very much, Professor Arafat, for a very interesting topic. The floor is open for discussion. Any questions, please? Okay, Professor Ali Azmi, please.
Thank you, Dr. Arafat, for your updated talk. Actually, you have elucidated very clearly the role of circulating DNA in prognostic and predictive decision-making in colorectal cancer. But my question about the circulating tumor cells, it has a prognostic value, but does it have a predictive value in decision-making? For example, if we take 7.5 millimeter of blood, and the number of circulating cells was above 5. Can we consider this in favor of giving chemotherapy of stage 2 colon cancer, for example?
The answer come with the last slides, the real patients I showed you. I think in the coming year, it could be, yes, we can give more chemotherapy or we can escalate the chemotherapy, but till now, it's not in the guidelines. I believe now nobody does just circulating tumor cells. They look for circulating tumor cells, but then they analyze the circulating tumor DNA. So after having this bad prognosis, we consider it as a bad prognostic factor. Even some people say it's a molecular metastasis. So if you have more than 5 in more than 3 in colorectal cancer, you consider it a molecular metastasis, and you should, in a clinical trial, treat the patient the way it's a metastasis. But of course, the DNA information will add value to the number of circulating DNA, because, as I told you, there is false negative regarding the hematopoiesis. Sometimes you misinterpret the circulating DNA for hematopoietic disease disorder.
Thank you. Professor Samsal.
Thanks for this excellent session. Liquid biopsy can be applied for any liquid in the body as malignant ascites or pleural effusion. We can detect CTC in this liquid type or only in hematological type or blood sample.
This is a very intelligent question. Most of the study have done on blood samples. Most of the study have blood samples, but I'm afraid that cells in the ascitic fluids could be misinterpreted because it's already in the anatomical guide. It's already in the staging system, the classic way we treat. It's if it is positive for ascites, but I believe the circulating tumor cells in the blood, this is an important part, because this is the cells that have that acquired the metastatic signal transduction that let the tumor pass the blood barrier and go to the blood, and this is the cells have the potential to make a niche and make more metastasis. But for acidic fluid, I don't think this will travel or go more than the original tumor. Thank you for your question.
Thank you very much, Professor Arafat, for a wonderful discussion. I think we will need a lot of time for until the guidelines will get a correlation between what we saw today, which was very interesting, to be correlated with our clinical outcome, which will help us as oncologists in our decision of management. Thank you. Now we go for the second session. I would like to invite Professor Dr. Tamer Nahas, my friend and colleague from Asr Al-Aini, Cairo University. He's going to give us a talk about the metastatic colorectal cancer. Consider sidedness and think molecular. Dr. Tamer, please.
Thank you, Chairperson, for the very nice introduction, and thanks for the organizing committee of Ain Shams University, Professor Dr. Iman Sharawi, and my dear, very active friend, Professor Mohammed Yassin, and the family of Ain Shams University for the outstanding event of today. So within the next 15 minutes, I don't know, they're giving me, Chairperson, 12 minutes. First time I just go to an event with 12 minutes, it's sharp, but I'll try to be very concise. So today I'm going to try to take you over during the next 15 minutes in how to think a little bit molecularly, and that's what we need to do and to apply in our different malignancy within the near future. So if we are going to take you to that point, I need to go to the background. The background, where do we come from? If we are talking now molecular medicine, so where we have been in the mid-90s with a very mediocre median survival, as you all know. Why am I showing you this slide? Why am I showing you a slide of improvement? Because we have many malignancy. You are not going to find this. If I'm going to show you the slides of sarcoma, you are not going to find any improvement during the last 2 decades. And if I'm going to show you the slides of small cell lung cancer, you are going to witness a very minimal response during the last few decades. So here is a real improvement. You can see with best supportive care until 2016, we crossed the 30 months median overall survival. You can see a lot of efforts from many physicians, like in the year 2000, Degramo and Philippe Roger have improved the classical way to give 5-FU in colorectal cancer by protracting the infusion time. And Philippe Roger have been one of the Ain Shams speakers probably 7 years ago. He chaired on this same podium many speaks on colorectal cancer. So with the evolution of medicine, second generation agent, irinotecan, oxaliplatin, biological therapy, anti-EGFR and anti-VEGF, like that, we have improved the outcome. And now we are furtherly speaking about immunotherapy, target therapy, and a lot of new agent in metastatic colorectal cancer. So the optimal sequencing have been very important to address. It's a very important issue in colorectal cancer. You need to implement your best agent in an upfront treatment, because when you implement your best agent in an upfront treatment, you get the highest response rate. And this highest response rate is implemented into the progression-free and into the overall survival. That's why when you have a patient with a conventionally curable or potentially curable, you need always to implement your best agent, because you are going to cure the patient. In colorectal cancer stage 4, you can still cure the patient. This is not the fact in metastatic breast cancer, but in colorectal, that's what we really did achieve. So what drive our decision for the upfront treatment when the patient come to your clinic? Many factors come into the consideration: a tumor characteristic, a patient characteristic. You have to look as a tumor burden. Can you convert this patient from an incurable to a curable disease, or it will be definitely indefinitely incurable? The tumor localization, the tumor biology, some factor related to your patient, his age, his performance, and so on. And what is recent now, how we can implement molecular biology and classification, consensus molecular classification in such a disease and what its impact on such a disease. So in back to 28, it was very easy. Medicine was very simple. You just add an anti-EGFR a la carte, regardless of any molecular marker, and we witnessed response. And that was astonishing for RAS mutant and for wild type RAS. That's what we got from the crystal and from the opus in the beginning of the evolution of biological therapy in colorectal cancer. However, with the evolution of medicine, and that's how medicine evolved by time, you start to understand which patient did benefit more from this agent. And we understood by time that patient having a KRAS mutation on exon 2 did not really benefit from what we call an anti-EGFR therapy. And when the medicine did evolve more and more, we did understand that evoluting of this predictive test to check on exon 3 and exon 4 and NRAS, we understood that 17% of patients who were thought to be RAS wild turned out to be RAS mutant. And this had led to a better stratification of the patient and with a better improvement. And as you can see, that wild type KRAS on the left side of your slide, you have an improvement of survival. And when you extended the RAS gene test to exon 3, 4, BRAF, and NRAS, you have improved your survival. And this is what we call how we can highlight the role of predictive medicine. So then came the issue of anti-EGFR or anti-VEGF in an upfront treatment. We had a lot of debates until we had the debate of the sideness of the tumor in colorectal cancer. And we understood that the right side colon is different from the metastatic malignancy of the left side colon. So if you move this tumor from the bad prognosis side, the right side, to the good prognosis side, the left side, you will achieve a better prognosis. So the side was not just enough for us as physicians. We did not want to apply just side by itself to say right side is bad and left side is good. This was not right. And that's what I'm going to try to convince you. What is the difference between the right and what is the difference between the left? So 4 main difference between the right and the left. First, from the embryonic part of view, the midgut is giving the evolution of the right side. However, the left side colon is coming from the hindgut. We have a different blood supply for the right side and a different blood supply for the left side. And most importantly, we have a different microbiome culture in the right and a different microbiome culture on the left, and what we call the consensus molecular subtype we are going to address in a few minutes in my speech. So as you can see that the microbiome is much higher in the right than in the left. We have different bacterial aggregates on the right than on the left. And this dense bacterial aggregate, which are present mostly on the right side, lead to increased cellular proliferation, increased invasion, and this gives the aggressiveness for the right side colon. Well, from the molecular alteration side, you can see that if you are going to check by this table, you are going to find an equal value between KRAS mutation between the right and the left. However, on the contrary, you are going to find almost 10 times higher incidence of BRAF mutation on the right than in the left. And we know that BRAF is a poor prognosis factor in colorectal cancer. And as you can see from this curve, the bottom curve, the orange line, is the right side colon. It's the worst. It's the worst in stage 4, and it's the worst even in stage 3. In stage 3, where you cure your patient with surgery and adjuvant treatment, you still have the worst survival for the right side colon. And if we are going to check between the right and the left, we have the famous CALBG study, which have recruited patients in upfront treatment to anti-EGFR versus anti-VEGF with a doublet chemotherapy. And you can see here from this study, again, the bottom curve is for the right. This is the overall survival. And the up curve is for the left, which having an improved survival for a left side colon. And this was endorsed from many other studies, like the PEAK study. You can see almost a doubling in survival between the left in comparison with the right side. So let us look at this curve. This curve simply conclude the fact that anti-EGFR and anti-VEGF implementation between right and left. You are going to find that the best and the up curve is for anti-EGFR on the left. and the worst is for the same medicine, which is anti-EGFR on the right. So anti-EGFR did the best for the left and the worst for the right. And in the middle, the two curves on green in dark green and in light green enlightens the value of BIVA. What about the new concept? And how can we differentiate? We don't accept right and we don't accept left. We just need to understand the biology between the right and the left. We now have what we call the consensus molecular subtyping of colorectal cancer. Like all of you know, that we have 4 different intrinsic phenotypes for breast cancer, the luminal A, the luminal B, the HER2 positive disease, and the triple negative. In colorectal cancer, we could stratify patient into 4 different consensus molecular subtype. The consensus molecular subtype 1, which is the immune, 2, canonical, 3, metabolic, and 4, mesenchymal. What is the difference? Consensus molecular subtype 1, which is classically present more on the right side, you are going to find a lot of MSI high population. You are going to find a lot of BRAF positive population. These are a little bit of worse prognosis. However, in the canonical 2, which is consensus molecular subtype 2, it's more present in the left side. And wild type is better prognosis, of course, than the mutant RAS. And again, you have a lot of somatic copy number alteration on consensus molecular subtype 2. So now we have 4 intrinsic different phenotypes. So if you come here to this pie chart and find what is the most common consensus molecular subtype on the right and what is the most common consensus molecular subtype on the left, you are going to find that the orange, which is the consensus molecular subtype 1, the immune subtype, which is with high MSI, with high BRAF mutation, is more present on the right side. Again, the metabolic is more present on the right side. This carry genomic alteration of worse prognosis. However, the consensus molecular subtype 2, which carry a wild KRAS and RAS, is the blue one, you can see on the pie chart, is more present on the left side. So the left side carry more quiet genomic alteration, the right side carry more aggressive, more hot genomic alteration. And if you are going to check between this different consensus molecular subtype overall survival in the CLBG, what we are going to find here very clear that the consensus molecular subtype 1 in green have the lowest survival. You can see on the left side of your curve, the green lines with the worst survival with the consensus molecular subtype 1, and the best with the white line up on the top, which is the consensus molecular subtype 2, which is the one with the wild type RAS, with the wild type with NRAS, and having a better prognosis. So a simple question, let's implement BIVA and let's implement cetuximab and let's check what's the value. You are going to find similar values like the previous slide. You are going to find that the green line on the left side have moved a little bit upward with bevacizumab. So in the consensus molecular subtype 1, which is immune, which is having high MSI, which is having BRAF mutation, BIVA could improve the outcome with consensus molecular subtype 1. But look at the left side with cetuximab. You are going to find that it worsens the outcome. It got the curve a little bit more down. So it have a detrimental effect. So if you give anti-EGFR in consensus molecular subtype 1, you have a worse outcome again. So BIVA improved outcome for consensus molecular subtype 1, and anti-EGFR like cetox did have deleterious effect. And this was the conclusion. I'm going to go quickly in that. So what about new personalized medicine? We have, of course, I don't have time to talk widely about that. They just give me 12 minutes, Mr. Chairperson. So I'm going just to touch not the Bacon study, not the Destiny study, but we are going to go into 2 minutes into the how to integrate immunotherapy in colorectal cancer. So we know that we have 2 kinds of colorectal cancer: the MSI high on the right side, and the MSS, which is on the left side. And we know now that the MSI high is more common in the consensus molecular subtype 1, which is more common on the right side colon. And you can see that the KRAS mutation is frequent in the chromosomal instability, which is on the left side. However, in the MSI high, as we said, we have a higher incidence to find a BRAF mutation. And here will comes a question to treat an upfront treatment with an with a PD-L1 inhibitor or with an anti-BRAF. Tumor burden is definitely higher in the MSI high population rather than in the MSS population. And the deficiency is coming from 4 different proteins. That's what you do at your pathologist. Your pathologist check for 4 different proteins, as you can see. And this protein, if they are the mismatch repair proteins, they are 4. These are proteins involved in the spelling mistake during the DNA replication with deletion or insertion. They just surveil the spelling mistake during the proliferation. If you have a deficiency in this mechanism, so you have a deficient mismatch repair gene. And by the way, that's what we call the Lynch syndrome. And these are a germline mutation. And patient carrying Lynch syndrome, by the way, have a 70 to 80% chance to develop malignancy. This is the penetrance of this gene. So at the time of the lifetime of the patient, 70 to 80% of patients will develop malignancies. So the first evidence toward a positive predictor of MSI came in 2015 with a publication in the New England Journal of Medicine. Very clear message. You can see how divergent is the curve. You have a predictive marker called the MSI, you have a treatment called the immunotherapy, and you can see the difference in the curve. And this from the pembro side have been tried in many malignancies, in uterine, in colorectal. Colorectal was the second malignancy. You can see the blue part of the pie chart, including colorectal. So it was the second incidence of malignancy in the study. And from phase 2, we did achieve real improvement in overall response, in progression-free survival, and hence came the famous keynote from Terry Andre as a primary investigator, challenging immunotherapy in an upfront, a very challenging study, a very unique study of immunotherapy and upfront treatment, and versus the physician choice of anti-EGFR biological therapy or anti-VEGF in combination with chemo. Dramatically, you can see that the progression-free survival have been improved. But what is the problem with this curve? If you see that the first 6 months here of this curve, you have a drop down of immunotherapy. You don't have a better chance. So 40% of patients dropped during the first 6 months on immunotherapy, according to the MSI as a predictive marker for treatment. But let me explain to you, it was not exactly 40%, because from the keynote 177, we understood that there was not central lab verification for the MSI. So almost 25% of what were thought to be MSI high were found to be MSS. And this was one explanation for the dropout in the first 6 months. Another explanation was the pseudo-progression. So in the keynote 177, they choose the RECIST criteria 1.1. So more than 20% increase in the tumor volume was considered as progression. And we, as you know, have a lot of pseudo-progression on the first few months. So there was some misinterpretation of the data. That's why we had, again, a drop down of the curve in the first 6 months in favor of chemotherapy. However, you can see that more than 50% had a real durable response. So when come a study now and asking, shall we add chemotherapy to immunotherapy in MSI high population? I would say simply 50% of this population does not need a drop of chemotherapy, not even a drop of chemotherapy. They have maintained their progression free for many years with no chemotherapy. And this is coming from the endured duration of response. And as you can see, the overall survival in favor of, numerically in favor of anti-immune therapy over physician choice. And all the key subgroup parameter were in favor of immunotherapy. One simple point here that you can see, which is KRAS mutation. For some time, we had a debate of KRAS mutation did not achieve the hazard ratio in favor of immunotherapy. But again, we had an alert that 30% from the 300 patients in the keynote study were not known to have whether a RAS mutation, yes or no. So this interpretation, you cannot use KRAS as a predictive marker for immunotherapy. So my final conclusion is that immunotherapy did improve meaningfully the progression-free survival, and it's now part of the guidelines in the upfront treatment of colorectal cancer. And as you can see from this algorithm now, that microsatellite instability come on top. So we are now surrogating patient on top. And I would say what is missing in this slide, it's not only microsatellite instability, it's the whole colon panel. It's the HER2 mutation. It's the BRAF mutation to surrogate your patients. And I would stop here. Thank you very much. I hope I was not long for you. Thank you.
Thank you, Professor Tamer, for this very elegant presentation, as usual. And really, you need a full conference for this presentation only. But as we are behind schedule, we can postpone questions for the end of session. And we need to move Harry for the second speaker.
Okay, thank you very much. Thank you, Chairperson.
Our next speaker will be Professor Muhammad Yassin, Professor of Clinical Oncology. Who will talk to us about cetuximab in colorectal cancer.
Thank you, Mr. Chairman. This is a Merck-sponsored lecture, but I want to highlight that Professor Tamer has made our talk and the talk of Professor Muhammad Farouk so easy because he has touched every single point in the management of metastatic colorectal cancer. So my speak will be only a recap of what Professor Tamer has said. Thank you, Professor Tamer. My talk will be cetuximab in metastatic colorectal cancer, the body of evidence for all of the trials. These are my disclosures. We all aware that left-sided and right-sided colorectal cancer are different in the embryological origin, are different in the function, are different in the microbiome, are different especially in the epigenetics and genetics. There is a difference between right and left-sided colon. The right side is around 20 to 40%, higher TNM stage, more mucinous type, and as Professor Tamer has said, CMS1 is the predominating molecular subtype. While on the left side, the predominating molecular subtype, which is better, is the CMS2. Tumor location in metastatic colorectal cancer is of interest within the clinical community from the CALGB trial 2016 to the two important meta-analysis of Holch and Arnold et al. In 2017, and the ESMO and the NCCN guidelines. Anti-FGR and anti-VEGF therapies are recommended for use across the continuum of care by international guidelines, the ESMO guidelines, ESMO Pan-Asian guidelines, and the NCCN guidelines. Before we start our treatment, we have first to define our goal of treatment according to the molecular subtype. If our goal is cytoreduction for all wild type, the standard of care for left-sided is doublet plus EFGR, for right-sided doublet plus BEVA or triplet plus BEVA, or even, remember, doublet and EFGR, because we have many positive trials for if our aim is cytoreduction in the right-sided for doublet EFGR. For RAS mutant and BRAF mutant, doublet plus BEVA or triplet plus BEVA. If our aim is disease stabilization, the story is different. On the left side, we use doublet and EFGR. On right side, doublet and BEVA. RAS mutant, doublet plus BEVA. BRAF mutant, doublet BEVA or triplet plus BEVA. If our patients are frail, the option is anti-VEGF BEVA plus capecitabine. What about the consistency of cetuximab trials in metastatic colorectal cancer? As we all know, cetuximab can be combined with FOLFOX or FOLFIRI, and even as a single agent for patients who cannot tolerate other treatments. For a combination FOLFOX, we have the OPUS trial, we have the TAILOR trial, and we have the CALGB trial. 73% of patients in the CALGB trial have received FOLFOX plus cetuximab or FOLFOX plus BEVA, and 27 have received FOLFIRI. On the other hand, the FOLFIRI trials are the CRYSTAL trial and the German FIRE3 study of cetuximab and FOLFIRI versus BEVA plus FOLFIRI. I will go very fast through the trials. In the OPUS trial, the overall response rate for cetuximab was 58% versus 29% for FOLFOX. Progression-free survival was 12 months versus 5.8, and the overall survival was 19.8 months versus 17.8. While in the Taylor trial, the overall response rate was 66.3 versus 40.5 for FOLFOX4. Progression-free survival was 9.2 versus 7.4. Overall survival was 20.8 versus 16.5. And the short median overall survival in both arms of the Taylor compared with CRYSTAL may reflect the fact that few patients received second and later line therapy. As we said before, 73% of the patients in the CALGB trial have received FOLFOX plus BEVA or cetuximab, and we see here overall survival with cetuximab plus FOLFOX or FOLFIRI versus BEVA plus FOLFOX or FOLFIRI in left-sided RAS wild metastatic colorectal cancer. The overall survival was 39.3 versus 32.6 for BEVA and FOLFIRI. In the CRYSTAL trial, cetuximab plus FOLFIRI overall response rate was 66% versus 39% for FOLFIRI alone. Progression-free survival was 11.4 versus 8.4, and the overall survival was 28.4 for FOLFIRI plus cetuximab versus 20 months for FOLFIRI alone, with a 31% reduction in the risk of death. In the FIRE3, and all the cohorts have received FOLFIRI plus cetuximab or FOLFIRI plus BEVA. The overall response rate was 65.8 versus 58 in the RAS wild type metastatic colorectal cancer, and progression-free survival was 10.4 versus 10.3, and the overall survival was 31.1 versus 25.6. In left-sided RAS wild type metastatic colorectal cancer, cetuximab plus chemo has consistently shown survival benefit versus BEVA plus chemotherapy. In the overall survival in FIRE3 trial for cetuximab plus FOLFIRI or FOLFOX, 36.4 versus 28.2 for BEVA plus FOLFIRI, and the overall survival in the CALGB trial was 39.3 versus 32.3 for BEVA plus FOLFIRI, in contrast to cetuximab. FIRE3, this is a very important issue. Second line overall survival and progression longer after first line cetuximab plus FOLFIRI than BEVA plus FOLFIRI in patients with left-sided RAS wild metastatic colorectal cancer. Progression-free survival from the start of second-line therapy. The red dot is first-line cetuximab plus FOLFIRI, and the green is first-line BEVA plus FOLFIRI. And for cetuximab plus FOLFIRI, it was progression-free survival from second-line from the start of second-line therapy, 6.7 versus 5.3, and the overall survival from start of second-line therapy, 17.6 versus 14.1, which means first-line cetuximab may sensitize tumors to subsequent anti-VEGF therapy in left-sided RAS wild-type metastatic colorectal cancer. Remember, we are talking about wild-type and left-sided. Real-world data have confirmed the overall survival benefit of cetuximab plus chemo over BEVA plus chemotherapy in patients with left-sided tumor, and we have a very important Japanese single-center retrospective case control study, which has shown the overall survival of 55.7 for cetuximab plus chemo versus 25.7 for BEVA plus chemotherapy. First-line cetuximab plus chemo sensitize RAS wild-type left-sided metastatic colorectal tumors for later-line BEVA plus chemotherapy, as shown by an observational retrospective Chinese cohort study. Meta-analysis, Holsch meta-analysis and Arnold meta-analysis are very important meta-analysis supporting the preferential use of anti-FGFR agents plus chemotherapy over BEVA plus chemo or for left-sided tumors. And here, 86% of left-sided anti-FGFR agent plus chemotherapy treated patients in the head-to-head trial versus BEVA plus chemo received cetuximab plus chemotherapy. Overall response rate favors anti-FGFR agents plus chemotherapy over BEVA plus chemotherapy in patients with right-sided tumors, again from the Holsch meta-analysis of overall response rate and Arnold meta-analysis of overall response rate. Also in the meta-analysis, cetuximab plus chemo showed superior overall response rate and progression-free survival than chemotherapy alone in patients with right-sided RAS wild-type metastatic colorectal cancer. So in right-sided, if we are talking about overall response rate or talk about cytoreduction, we can give doublet plus anti-EFGR if our aim is cytoreduction as an option, besides the option of BIVA or plus doublet or triplet. The addition of cetuximab to FOLFOX in both left-sided and right-sided RAS wild-type metastatic colorectal cancer improved long-term survival rates in the Taylor trial. In the Taylor trial, 3-year overall survival, progression-free survival, and overall response rate were superior for cetuximab plus FOLFOX4 compared with FOLFOX4 alone in both left-sided and right-sided wild-type metastatic colorectal cancer. And if we look at the 3-year overall survival rate, in left-sided tumor, it was 32% for cetuximab plus chemo and 16% for chemo alone. And in right-sided, cetuximab plus chemo was 23% versus 14%. If our aim is tumor shrinkage, there is a high hope for survival, and we all know that high tumor burden is associated with poor performances and poor survival in metastatic colorectal cancer. High tumor burden is associated with shorter overall survival than medium or low tumor burden. As a result, tumor shrinkage is the foundation of effective treatment in metastatic colorectal cancer, which enhances resectability and provides potential for cure, improves symptoms, and delays onset of recurrence of symptoms in patients with aggressive disease, high tumor load, changes patients' mental status from depression to hope for cure. Anti-FGR therapy plus chemotherapy improve overall response rate versus chemotherapy plus BIVA in left-sided metastatic colorectal cancer, as we have seen, and 86% of the patients have received cetuximab plus chemotherapy in the meta-analysis of comparing anti-FGR versus plus chemotherapy versus BIVA and chemotherapy. And if we look here, as a proportion of resected patients was higher with cetuximab plus chemotherapy, 105 patients from 578 versus BIVA and chemotherapy, 75 patients only from 559. And also on the right side, there was a higher rate for resected patients in the cetuximab plus chemotherapy versus BIVA and chemotherapy, and 83% of the patients with right-sided RAS wild-type metastatic colorectal cancer have received anti-FGR treatment in the form of cetuximab plus chemotherapy. So cetuximab plus chemotherapy provides superior tumor shrinkage and overall response rate versus BIVA plus chemotherapy in liver-limited metastatic colorectal cancer, as we have seen in the ATOM trial. And the FOLFOX6 plus BIVA median tumor shrinkage at week 8 was 25.3%, while for cetuximab plus FOLFOX, 37.8%, and the overall response rate was 68.4% for BIVA plus chemotherapy versus 84.7% for cetuximab plus chemotherapy. So the concept of converting to resectability, unresectable chemotherapy plus or minus targeted therapy, responders, conversion to resectability, at the end, there is a high hope for cure. Tumor shrinkage is important to allow resection and increase the possibility of cure. Anti-FGR plus or minus chemotherapy have a clinically important role in the conversion to resectability, and several factors influence the decision to resect. Patient comorbidities and preference, technical difficulty of surgery versus anticipated patient benefit, availability of specialist surgeons, need for regular assessment, MDT involvement. And if we see here from the FIRE 3 cohort, either in the university hospitals or non-university hospitals or oncology medical practice, there was a higher percentage of patients who have recommended resection at best response, and also a high patients of resection of metastasis. Response to therapy and conversion hepatectomy are independent prognostic factors for overall survival in metastatic colorectal cancer, and conversion hepatectomy and response to chemotherapy plus targeted therapy are independent prognostic factors for overall survival. FIRE 3 increased early tumor shrinkage rate with Erbitux plus FOLFIRI versus BIVA plus FOLFIRI in RAS wild type. And if we look here, early tumor shrinkage for Erbitux plus FOLFIRI, the median overall survival was 38.3. And if there was no early tumor shrinkage, the median overall survival was 20.5. While in the BIVA arm plus FOLFIRI, if there is early tumor shrinkage, it was the median overall survival was 31.9 versus 21.2 if there was no early tumor shrinkage. So early tumor shrinkage was significantly associated with prolonged survival independent of the treatment arm. Again here, if we look at the delta difference in the CRYSTAL trial for patients who had early tumor shrinkage less than 20% or early tumor shrinkage more than 20%, the delta for FOLFIRI plus cetuximab was 11.4, and in the FIRE3 study, it was 17.8, and the tribe of triplet therapy plus BEVA, the delta of benefit for patients who are early tumor shrinkage less than 20% versus early tumor shrinkage more than 20%, the delta was 10 months. Evaluation of depth of response. Depth of response is the percentage of maximal tumor shrinkage observed at the nadir compared with baseline. In the KRAS exon 2 wild population, in the FIRE3, early tumor shrinkage was for epitox plus FOLFIRI 62.3% versus 47.9 for BEVA, and the RAS wild population, epitox plus FOLFIRI was 68.2 and 49.1 for BEVA plus FOLFIRI. And the median depth of response is very important for epitox plus FOLFIRI in the exon 2 was 44.1 versus 32.9 for BEVA plus FOLFIRI. And in the RAS wild population, it was higher. It was 48.9 versus 32.3. If we look here, the median depth of response for cetuximab plus FOLFIRI from the FIRE3, it was 48.9, as we have mentioned, and BEVA plus FOLFIRI, it was 32.3. The median overall survival was 33.1 versus 25, and the progression-free survival was 10.3 versus 10.2. So depth of response correlated with significant overall survival and progression-free survival, and also patients with right-sided tumor who have early tumor shrinkage more than 20% have similar outcome with cetuximab plus chemotherapy to BEVA plus chemotherapy. Cetuximab plus FOLFIRI provides early and profound tumor shrinkage in patients with right-sided RAS wild-type metastatic colorectal cancer from the FIRE3 cohort. Early tumor shrinkage for cetuximab plus FOLFIRI was 56.7 versus 42.1, and the depth of response was 25.8 versus 17.7. And also cetuximab improves the rates and R0 liver resection, initially non-resected liver limited disease, as we have seen from the CRYSTAL trial, 71% versus 44, and R0 resection 13.2 versus 5.6. In the OPUS trial, 76 versus 39, R0 resection 16% versus 4.3, and the SELEM trial, which is a single study, response was 70% versus R0 resection 33, and in the triplet poacher study, the response was 79, and the resection rate R0 was 60%. At the end, the safety of cetuximab, if compared to other anti-EGFR panitumumab, serious adverse events were 28.4% for cetuximab versus 35.6. Fatal serious adverse events were 2.9 versus 4.5. At the conclusion, weight of evidence, erbitux is the anti-EGFR agent with the strongest evidence compared to BEVA plus chemo for patients with left-sided RAS wild metastatic colorectal cancer, as Professor Temer have showed in his slides. Efficacy, erbitux is the only anti-FGFR therapy with a proven overall survival benefit versus BEVA plus chemo in the phase 3 trials. As regarding safety, erbitux-based therapy is associated with lower rates of grade 3 and 4 skin reaction, hypomagnesemia, discontinuation, and fatal adverse events. Mode of action, erbitux is the only anti-FGFR monoclonal antibody that can trigger an immune cascade through antibody-dependent cell-mediated cytotoxicity, leading to changes in the tumor microenvironment. Thank you for your attention.
Thank you, Professor Yassin, for the very nice illustration, as usual, and for demonstrating the role of cetuximab in advanced colorectal cancer. Unfortunately, because of the time, we will not have some time for questions right now, but we have the speakers available if you would like to ask them any question about their topic. Thank you, Dr. Yassin. And now I have the honor to ask Professor Dr. Muhammad Farouk Mustafa to join the stage. Muhammad Farouk Mustafa is a professor of clinical oncology in Alexandria University. He is expert in many types, almost all types of of cancer, but he is dedicated. It's dedicated and specialized in the GI cancer, especially the colorectal cancer. And in Alexandria, we always refer to him when we need an expert opinion in colorectal cancer. Today, Dr. Farouk هيتكلم على الرول of immunotherapy in metastatic colorectal cancer, which is the topic of interest these days, and we will have an overview about it. Dr. Farouk, please.
سي دكتور حازم على الانترودكشن الجميله دي. أهلا بحضراتكم. It's my honor to be with you today. I have to thank Professor Dr. Iman Sharawi, and I have to thank my dearest brother, Dr. Muhammad Yassin, for giving me the opportunity to be with you today. My talk today will be about immunotherapy in metastatic colorectal cancer. In the upcoming 15 minutes, I'm going to give you an introduction about the immunogenicity of colorectal cancer, some data about the proof of concept trials for the use of IOs in DMMR, the landmark clinical trial with some explanations, the shift of the immunotherapy in the neoadjuvant setting and what is expected in that field, and some data about converting cold tumors into hot. If we started with 100 patients with localized colorectal cancer, we can find that chromosomal instability is responsible in 70 to 80% for the pathogenesis. On the other hand, we will find 15% only are the cause of, in 15% the cause is microsatellite instability. If we imagine that here there are mutations in the DNA, these mutations is responsible for the tumor mutational burden. And then if the mutation has been transferred on the protein level, it will be the neoantigens that will be expressed by the endoplasmic reticulum to the major histocompatibility system, which will introduce it to the lymphocytes. And thus, if we plotted here the tumor mutational burden, in addition to the neoantigens and the activity of the major histocompatibility system on one axis, and on the other axis, the BDL1 expression in the tumor microenvironment, we may got 4 different types of cancers related to the immunogenicity in colorectal cancer. 2 of them are very active and very responsive to colorectal cancer. These are the microsatellite unstable and the polyhypermutated tumors, while the microsatellite stable, whether these stable lesions are having high tumor burden or low tumor burden, they are less responsive. And this had been validated in the very nice paper. This nice paper had been published in the New England Journal of Medicine the last year. And actually, no. اللي بيرجع فين؟ As you can see here, the difference in survival is completely, there is a complete difference in survival between the polymutated and MSI mutated lesions and those who are having macrosatellite stable disease. And as mentioned to you, this had been published in the New England Journal of Medicine 2021. Dealing with patients with DMMR, they are having high mutational burden in most of the cases, not all the cases. They are having high lymphocytic infiltration in nearly 2/3 of the cases. When they are presented in stage 2, they carry excellent prognosis, no need to give adjuvant chemotherapy. When they are present in stage 3, again, they carry excellent prognosis, and we have data from the accent pooled analysis of 12 adjuvant trials documenting that we need oxaliplatin in this situation. In stage 4, actually, we can't reach a conclusion whether this is having good prognosis or not having good prognosis, because we have higher incidence of PRAF mutation, which may counter the prognosis, the good prognosis with the MSI cases. So in stage 4, we cannot reach the conclusion whether these are having good prognosis or bad prognosis, but we are very sure about the predictive value of the MSI to immunotherapy. The proof of concept trials. The proof of concept trials, we have the Keynote 164 documenting that Pembro in patients previously treated 2 lines or more had a 35% response rate. Checkmate 142, in one arm, that is Nivo, the same 35% response rate. And in the second arm, when Nivo was combined with Ipi, we have a 50% response rate. And even in the third arm, when Nivo-Ipi was used as a first line in a small cohort of patients, a 60% response rate had been achieved. the response rate is not very important. What is important is the plateauing of the curves of the progression-free survival you are seeing in front of you. The curves are plateauing, and the PFS in both trials and also the overall survival is plateauing in both trials. And that means that there could be a group of patients that may be cured from their metastatic disease. This was confirmed after the publication of 4 years follow-up of the Checkmate 142. You can see here clearly 50% of the patients are alive at 4 years without progression, and 70% are alive. The third trial is the Garnet trial, evaluating the starlimab, the famous drug, in those patients also, and documenting a 42% response rate, and again, plateauing of the progression-free survival curve. Of course, the seminal trial and the main trial in this field is the Keynote 177, 270 patients, stage 4 disease, and DMMR or microsatellite unstable, randomization, Pembro versus the investigator's choice, and as you can see, doubling of the progression-free survival. We are talking about 8 months that had been transferred into 16 months. Overall survival, trend towards improvement in the overall survival that didn't reach the level of significance. All subgroups got benefit from the Pembro. Very important why it didn't reach the level of significance, because in the control arm, 60% of the patients received immunotherapy, including the Pembro in this trial. What is important here, when you look for the response rate, you can find that we have a 45% response rate in these patients. But in the same time, with the Pembro, we have 30% of the patients progressing on Pembro. That means we have 2 groups of patients, a group of patients that got benefit from the immunotherapy, and these are the majority, but we have 30% of patients that did not got benefit from the immunotherapy, and they can benefit from the from chemotherapy well. Of course, looking at the forest plot, trying to identify these patients was without any value, and this phenomenon is seen in all trials evaluating immunotherapy in the second and third lines. We have the responders, but we have at least 30%, what is written here in red, that are progressing on the treatment and they need chemotherapy. Why curves crossed before 5 months? Actually, there has been no definite conclusion, but we have at least 4 explanations, as Professor Tamer has mentioned. In 8 to 10% of the patient, there was error in the diagnosis. They were having MSS and not MSI tumors. The tumor mutational burden, when it is high in this patient with microsatellite instability, you can find an excellent survival. But not all patients with microsatellite instability are having this high mutational burden. We have at least 20%, you can see them here. 20% of the patients are having a low mutational burden. And this was validated by 3 different retrospective data. All of them documented that these patients, there is a difference in survival according to the tumor mutational burden, and take care. All these patients were having a microsatellite instability disease. False pseudo-progression or forced progression in 10% of the cases, but please take care. This occurred within the first 3 months of treatment, and in order to diagnose pseudo-progression, there is progression on the radiology, but your patient is improving. There should be a clinical improvement for your patient, less pain, weight gain, reduction in the biochemicals. This is very important. The last explanation is the development of fusions, new fusions, which may lead to a sort of resistance to immunotherapy. Do we have any markers that can we pick up those who are going to respond or those who are not going to respond? Actually, trials and most of them failed. The different groups, KRAS mutation, KRAS wild type, PRAF mutation, all of them benefited from the immunotherapy. TMP, yes, this could be the solution, high TMP versus low TMP. But the problem in the cutoff value, the cutoff value can see 10 in some trials, 27 in some trials, 37 in other trials. So there is no conclusion about the cutoff value in this TMP. This last one is the tumor infiltrating lymphocytes. Could they help? Actually, in 1/3 of the patients, the tumor infiltrating lymphocytes are low and the response rate approaching 40%, which is excellent. So they cannot be used as a marker. What is important here is the evolution of the immune system, immunotherapy in patient in the neoadjuvant setting. We are talking in the metastatic setting about 5%, but we are talking about 15% in the non-metastatic or neoadjuvant setting. In this group of patients, we have data from Netherlands. Professor or Dr. Mariam Chalabi did two important trials. The first one is the niche study. The niche study was a study evaluating Nivo in addition to Epi in patients who have non-metastatic colon cancer. After 6 weeks, they underwent surgery, and you can see here, look at the response, 100% pathologic response. Not pathologic complete, 100% pathologic response, including 70% complete pathologic response and 30% major response defined as less than 10% viable tumor tissue. Not only in the DMMR, but also in the pMMR, you can find that 30% of them responded, and including 13% complete responders. This is in the pMMR. Can you imagine? It seems to be that the tumor environment is completely different in the neoadjuvant setting than in the metastatic setting. We have, of course, the famous trial of the starlimab evaluating this drug in the neoadjuvant setting in patient with rectal cancer and documenting complete clinical response in 100% of the cases. And after median follow-up of 6 months of finishing the trial, we can see that there is no one with residual tumor till now. And we have the niche 2, which has been published in the last ESMO 3 weeks ago. And in this trial is designed for patients with microsatellite unstable disease, all of them, 102. First, they received first cycle Nivo Epi and second cycle Nivo. Then 6 weeks, they underwent surgery and take care that all these patients were having high volume disease. 75% of the patient high risk stage 3, 62% are having T4 disease, 62% are having N2 disease, and these are the responses. Major response in 95% of the patients with 67% pathologic complete response. Excellent, of course. And what's important is that it helped patients with Lynch syndrome and non-Lynch syndrome. Why there is disturbance, why there is difference in the response rate in the early versus the late? As you can see, here is in the metastatic setting, the response rate ranges between 30 and 60%, but in the neoadjuvant setting, we are talking about 100% pathologic response, 100% clinical response. This is very evident, and it must be studied well. Maybe the explanation, what is the mechanism behind the difference in response in the metastatic and neoadjuvant, maybe the tumor escape phenomena is responsible for that. Now, a few last slides about, can we convert a stable or hot tumor into a cold tumor into hot tumor? Actually, several attempts, the module trial evaluating the addition of atezolizumab to bevacizumab and capecitabine in the maintenance setting and failed. What is important, the Rigo Pembro trial, we can see that several data evaluating the combination of Pembro in addition to the regorafenib. The response rate was 22% in one trial, 33% trial, but the last trial, which is having the highest incidence of patients, failed to show improvement. Some data about inhibition of the MYC signaling, but again, the response rate was less than 3% and failed. This is an important trial, the Atezo trial, in which the addition of Atezo to the FOLFOXIRI or modified FOLFOXIRI regimen was associated with a better progression-free survival, and it should be evaluated in larger scale patients. And this is an important trial, which is the Maya trial. Maya trial is a proof of concept trial. They used temozolomide in patients who received several lines because temozolomide is characterized by inducing mutations, hypermutations in the tumor in patients who received several lines of treatment. This is in the GBM and in the colorectal cancer. And for responding patients, as you can see, after they responded to 2 cycles of temozolomide, there will be the addition of epi-nivo into the temozolomide. And as you can see, the primary endpoint was reached in the Maya trial, that at 8 months, the progression-free survival was 36, and the response rate to these patients were 42%. This is my conclusion slide. Colorectal cancer has two distinct groups of patients based on the sensitivity to the immune checkpoint inhibitors, the hypermutated tumor and the non-hypermutated tumor. All patients should be tested for the MSI at the start of treatment. Patient with MSI, advanced colorectal cancer, can be treated with the first line Pembro, and on the second line can be treated with Nivo-Epi. Neoadjuvant immunotherapy is promising, but not yet a standard of care. The MSS colorectal cancer is immunologically cold, and despite the early promise, no pharmaceutical approach using immune checkpoint inhibitors has yet been validated, and these patients should not receive immunotherapy inhibition outside clinical trials. And thank you for your time.
Thank you very much. Thank you very much, Professor Farouk, for a very interesting and elegant presentation. I know that we are out of time, so thank you very much. We're going to close the session and we'll go for the next session. Thank you.